that was created shortly after the attacks of 9/11 way back in 2002 as a way to address a magnitude of different disasters and threats to our healthcare system. The program is managed by the Department of Health and Human Services, the Bureau of EMS, Trauma and Preparedness. And really the foundation of our healthcare preparedness program at the state rests with our 8 healthcare coalitions located throughout Michigan. These are made up of representatives from hospitals, local public health, EMS, emergency management, long-term care, social service organizations, and tribal health. Each coalition has a regional coordinator, an assistant coordinator, and a medical director. For those of you located in kind of West Central Michigan, Dr. Jerry Evans is your regional medical director. You're located in Region 6. The coalitions are responsible for providing medical coordination and planning and emergency logistical support, which kind of goes in the last few months with the pandemic well beyond what we ever really, I think, envisioned. Just for reference, a lot of the talk will coming up will focus on Southeast Michigan. They're worthy of 2 regions, 2 North and 2 South, 2N and 2S. And just for reference, Region 7s and 8 are in the northern part of Michigan, Region 8 being in the UP. So our first 2 cases of COVID were identified in Michigan back on March 10th. Seems like a long time ago. And those occurred in Oakland County, very close to the city of Detroit. What we subsequently experienced this spring was an asymmetric epidemiologic distribution with extreme activity in Southeast Michigan, in particular in the city of Detroit. And at the same time, we had relatively sporadic activity throughout the rest of the state. And this was really similar to many other states. New York State, shows something similar in terms of the New York metro area being on fire, but relatively sporadic activity upstate and in neighboring Pennsylvania. Between late March and early May, Southeast Michigan really experienced just extreme conditions within their healthcare system. Peak hospitalizations of over 4,400 patients, 12 days with over 1,000 patients on ventilators, and it's just in Southeast Michigan alone. I think the top we identified was 1,223 ventilator patients on one day. And 176 intubations, or patients being put on mechanical ventilators on one day, which is just really unimaginable. New York City identified its first case 10 days before Michigan did on March 1st. And this graph illustrates the daily hospital admissions in both New York City and in Detroit, within the city of Detroit proper. And New York is in red, Detroit is in orange. Given that the population of New York City is like over 12 times that of Detroit, New York City has 60 some hospitals, Detroit has 6 hospitals. No real surprise that the red bars far overshadow the orange bars. However, if you look at this other graph, which is similar, what we've done here is try to normalize the healthcare stress in terms of hospitalizations by normalizing for 1 million population. So we're kind of making a little bit more of an apples to apples comparison. And here what you see is that on about a third of the days, Detroit actually would exceed the number of hospitalizations per million compared to New York City. And we all know and heard how bad New York City had it. I think sometimes that might have overshadowed how absolutely awful Detroit had it. Just to drive that point home, if you look at the mortality rate in New York City, 40 days after their first case, mortality rate looking at number of COVID-related deaths per million, they were at 646 in New York City. And in that same 40-day period, Detroit was at an astonishing 919 deaths per million. And this just all really reflects how bad conditions were in that Southeast Michigan area and Detroit in particular. This next graph is just a screenshot of a model that there was a number of models that we saw in late March that raised significant concern at, I think, all levels, but particularly at the state level, about the potential for a catastrophic failure of the state's healthcare system, with demands for hospitalizations potentially far exceeding the available beds. And this chart, which comes from covidactnow.org, a nonprofit site that provides, we think, reasonably good information. This was supported by a number of other modeling systems that the state used. That horizontal line, or slightly inclining horizontal line along the bottom of the graph, represents slightly expanding bed availability statewide, reflecting a surge in beds that were expected to occur. That steep mountain-like red curve is reflective of what would happen if there was no public health interventions done in Michigan. And you can see that goes way, way, way above the available beds that we were projecting. The slightly flatter bell-shaped, I don't know what is that, orange curve, represents what was modeled to occur if there was just simply 3 months of social distancing. And it was apparent that wasn't going to help with the massive demand on healthcare services. So if you can barely see along the very bottom, below the black horizontal line is a blue, green, teal colored curve that's very flat. And this is reflective of what was modeled for 3 months of shelter in place. And obviously that's the direction that the state went, but this provides some of the information, the kind of information that led to some of those policy decisions. These next several graphs might be a little bit nerdy and might be a little hard to follow. I apologize for that, but I think they're important to illustrate what I'm referring to as round one versus round two. We're going to look at the total number of hospitalizations by region. And again, the 2N and 2 South are Southeast Michigan. Region 6 is West Central Michigan. 7 and 8 are up north. Region 5 is Southwest Michigan, below Region 6. This first graph shows the hospitalizations that have been normalized to reflect hospitalizations per 1 million from a period from April 4th up to April 26th. Actually, the heading of the slide's off a little bit. And you have to notice how the 2 Southeast Michigan regions are really exponentially higher in terms of hospitalizations than the 2 Western regions and the 2 Northern Michigan regions that kind of go right along the bottom. This is subject to change in round 2, but I think it really shows that kind of dichotomy in the epidemiology that we saw, from severe impact in Southeast Michigan. Region 3 is Flint and Saginaw, kind of East Central Michigan. Now looking at more current data from the last couple of weeks, from October 18th just the other day, this looks at all of our regions again with hospitalizations per million. And notice that we don't see the extreme asymmetry that we saw in Southeast Michigan. The region 2 North and 2 South are kind of buried in the graph with everyone else. And that thick line is the aggregate, represents the total state hospitalizations per million. I think the thing that is noticeable is every one of those regions shows an increase in the number of COVID hospitalizations every day. So that has not yet started to level off. And that's why it's so important that we get this under control, because we can't have this type of continued trajectory. So not trying to overdo these 2 graphs, but I'd like to just take a second to juxtapose them and let you look at round 1 versus round 2. If you look at the y-axis, which is on the right graph, you can see that it goes up to 250. That's our current round 2 data, and 250 hospitalizations per 1 million. If you look at where that would be on the graph on the left, it's that bottom section, the very bottom part, is where the 250, 300 per million. So you can see that the activity statewide now is at a level that is still representing kind of a bottom of what we experienced in the spring. And this is just going to do the same kind of thing with looking at ventilators per 1 million. Fortunately, fewer patients on ventilators than patients admitted. And this is from round one. And again, it kind of parallels that other graph that shows the Southeast Michigan area being particularly hard hit. And the four Western and Northern regions just kind of go along the bottom. And, we got a little bit of a pass in the spring. And now look at today, and this looks like, I don't know, just a bunch of spaghetti in here. But the point is with this is that it's much closer. We don't have that dichotomy that we saw with Southeast Michigan being way above everyone else. They continue, Region 3, Flint, Saginaw area, and Southeast Michigan continue to be towards the top. And if you can see that green bar, it's like, I don't know, it now has become towards the very top. That's West Central Michigan and Region 6. So kind of a standardization or normalization, I guess, of the experience with ventilators. And then this is just that contrasting slide. So we are seeing a radical reduction in the number of patients on ventilators compared to what we were seeing in the spring. And that really, I think, is reflecting clinicians having a much better idea of this disease process and a few therapeutic interventions that might help to mitigate the need to put patients rapidly on ventilators. But we're still, in terms of ventilator use, we're still way, way below what our peak was last spring. So enough of the nerdy slides, just to kind of finish up here, a couple comments with the state's response system. Really the three kind of pillars of the state's healthcare support strategy is to be able to support the hospitals and healthcare systems as they surge up to meet increased demands. Relief healthcare facilities are another part of the strategy, and alternate care sites. There's a saying in emergency management that all disasters start and end locally. And the foundation of our state strategy is for hospitals to maximize their surge potential. For many years, hospitals have been asked to have to be able to rapidly surge up to at least 20% above their average daily census. Last spring, when things were very bad, we went out and asked hospitals to go up to at least 50%, if not higher, above their average daily census. Many hospitals actually doubled their numbers of beds during that time, which is amazing. An important concept, though, is we talk about beds, we have to also remember capacity versus capability. Capacity are the beds, capability is really the ability to care for patients there. So a number of things that we can do to help expand the surge capacity, including helping with logistical support, like trying to find ventilators. I won't even get into PPE, and helping to provide support for hospitals. This is a busy slide looking at how we've moved patients around the region and around the state. And you can see about 80% of the patient movement occurred in Southeast Michigan. Primarily, this table reflects hospitals moving patients about 30% of the time within healthcare systems. About 20% of these patients were on ventilators. And then finally, the topic of alternate care sites is kind of our in the toolbox as a last effort here. And we saw two alternate care sites stood up in Southeast Michigan, one at the TCF Center, which was for 900 beds, and in Oakland County, that was in Detroit, and in Oakland County, 250 beds, Suburban Showcase. These have limited capabilities, but they can handle low or even intermediate patients, and post-acute care can be provided. They have the ability to provide low flow, sustained oxygen, but this is a kind of a crisis standards of care that we would really like to avoid if we can. And fortunately, these were opened up right at about the time the demand for healthcare system in Southeast Michigan kind of plateaued. So they were never really used anywhere near how they were intended in terms of the volume. They saw small numbers of just a handful of patients rather than hundreds of patients that we were preparing for. So with that, I'll turn it back over to Dr. Nagelkirk, and thanks again for the opportunity to participate today.
Thank you, Dr. Bales. That was a great presentation, a great overview of the pandemic for our healthcare delivery systems. Now I have the privilege of introducing our next three panelists together, as they have worked collaboratively on their PowerPoint presentation and will be presenting the information together. I will introduce them in the order that they will be presenting, and you'll be able to see them all on the screen. Dr. Joshua Koistra is the Senior Vice President and Chief Medical Officer at Spectrum Health. He provides medical oversight for 12 acute care hospitals, 180 ambulatory care sites, and 4,500 employed and independent physicians and advanced practice professionals. He has been instrumental in the collaboration between the emergency room departments, inpatient floors, and intensive care units to develop protocols and improve care coordination. Previously, Dr. Koistra served as the Department Chief, Acute Health and Continuum Care. He completed his medical school program at Michigan State University's College of Osteopathic Medicine. Dr. Matt Biersick serves as Mercy Health St. Mary's Chief Medical Officer. In his role, he has provided leadership in the implementation of a new electronic medical record. Dr. Biersick co-leads the hospital's COVID-19 response. He has served as a hospitalist physician, medical director of clinical quality and patient safety, and Mercy's Health Chief Quality and Patient Officer. Dr. Biersick completed his bachelor's in nuclear engineering and radiological sciences in 2002, and at the University of Michigan College of Engineering, and attended Wayne State University's School of Medicine. Dr. Ron Gripka oversees more than 500 Metro Health physicians. He provides leadership to medical education and serves as the Chief Clinical Quality Officer for the organization. Before joining Metro, Gripka was professor of pediatrics at the Mott at the University of Michigan and attending cardiologist at CS Mott Children's Hospital. At Mott, he was director of the Cardiology Outreach Program, director of the Pulmonary Hypertension Program, and director of the Mott Partners in Pediatric Care Conferences. For the last 2 years, he was also the Associate Medical Director for Strategic Planning and Business Development for the University of Michigan Health System. Gripka has published many manuscripts and has a patent for a device for congenital heart defects. Please welcome them all, but we will start with Dr. Koistra.
Thanks, Dr. Nagelkirk, for that kind introduction for all three of us. I'm very happy to be joined by my colleagues and I can say friends as we've gone through this pandemic together. We've worked very closely. I get to start and just present the overall landscape of COVID-19 and really kind of our experience as being chief medical officers and being the leaders of a pandemic response across our health systems. The other guys wearing ties today who told me they weren't going to wear ties are going to take the more cerebral topics of current treatments and testing and vaccine development. And then we will come back and just talk about how we're collaborating together across different systems. If I could have the next slide. So back in late February, early March was really when things kind of got real for us as health systems. I remember I was actually on a ski trip with some college guy friends in Telluride when we were just kind of talking about the virus starting in Wuhan, China, and coming across and starting to see it in the state of Washington, watching many deaths at the nursing home that initially got infected in Washington state, and then watching it just start to come into New York City. And I got a call from my boss who said, Josh, when you get home, things are going to look a lot different. You're going to have to clear your calendar. We're opening up a command center. Things are going to get real. And that was about the same time that they shut down schools. And we were talking, among friends and saying, geez, do you think we're going to get to go on spring break? Little did we know, what this pandemic would really turn into. And then looking, as the week went on, what was happening on the east side of the state and watching our colleagues really suffer, having very difficult times caring for the onslaught of patients that Dr. Fowles just referenced. Next slide. So I think all three of us opened up command centers within our hospital systems, and they were very similar. We wanted to open these up to provide 24/7 oversight across all of our hospitals, to have real-time data to know what was occurring. So we built dashboards that would show us how many inpatients that we had, how much supply we had on hand for laboratory testing, for our PPE. We stood up camps, we call them camps, they were kind of subcommittees. We had an inpatient subcommittee, emergency department subcommittee, a treatment and testing work group, a PPE work group, a labor pool, and really had an all hands on deck approach. I laugh because, you know, our first command center, which was in a physical structure called the command center at Butterworth Hospital, is a small room that we probably had 20 people in, all unmasked. And as the pandemic went on, our command center got larger in its physical footprint, and we started to space a little bit more and then started to wear masks. And now our command center is entirely virtual as the pandemic has evolved. So if I can have the next slide, please. So we created all of this and we were ready to take on the world, kind of like we were watching in the Detroit area. And really, we never saw the surge that Detroit had. And we shut off everything due to executive orders that were coming out and what we thought was best practice, and really turned off all of our elective surgical care, all of our elective radiology studies, recognizing then that, boy, the community is not getting the care that they typically get. And we started to see some late presentations of cardiac illness. We started to see some cancer diagnoses that were delayed, and really recognized that we needed to turn back on services and let our communities know that we were able to provide safe care. So we had a myriad of mitigating strategies that we put in place with visitor screening, visitor restrictions, sanitization practices, and really had an ad campaign that let our communities know that it's okay to come in to get care into our systems. And I think we all had different versions, but similar messages. Next slide, please. All right, and so this is a slide that just, it's a little bit busy, but what each of these lines represents is one of our 9 clinical service lines that we had at Spectrum Health. And you can see on March 12, when we gave the order to shut down everything, we rapidly did that. And these are the percentages there are the number of daily visits that we had within each of those service lines. And you can see about late April, when we realized that we really needed to start turning back care on for our community, our teams really rallied and were rapidly able to do that. And right now, we're about 95% of the services that we were offering back before the pandemic started. Next slide, please. So another landscape that I want to lay is really the racial disparities that were brought on and recognized from COVID-19. We noticed, if you look at the graph on the right, that's our demographics in Kent County by race. And if you look at our admissions by race, our Black and brown communities really suffered initially from COVID-19. That's starting to change now as we look at our demographics. But for certainly what we were seeing in the spring and summer was a great disparity of the impact of COVID-19 on these communities, and really highlighted or shone a spotlight on underlying healthcare disparities across our communities that we need to address. And then next slide. There we go. And at about the same time, we also had the death of George Floyd. I think it was May 25. And really this further highlighted some disparities that we have in our communities. And this was an event that took place called White Coats for Black Lives, where we had over 300 physicians and APPs gather in recognition of the tragedy of George Floyd's death, and had a kneeling event for 9 minutes out on the football field across from our hospital. Next slide. So looking at our mortality rates across the pandemic from early on until now, we see that we've slowly improved the way that we care for these patients. There's been evidence-based trials that have helped guide us. Initially, we didn't know whether hydroxychloroquine was effective. We were using it in some of our protocols. We didn't know whether delayed intubation or early intubation was best. We didn't know about prone ventilation as much as we do now. And through all of these learnings and scientific evidence that's come to light, we've slowly been able to improve the mortality of our COVID-19 patients. We are hovering roughly right around 10%, and this is for our admitted patients, and then the patients who die would be the numerator, the admitted patients would be the denominator for this. Next slide, please. So our lessons learned, one, it's difficult to operate in a poor data environment. I think that's why we saw those higher mortality rates early on. Next, we want to be mindful of anecdotal data and poorly designed clinical trials. Certainly, we saw that early on about different treatment options that people thought were available, and even some kind of fraudulent scientific literature that was highlighted in journals such as the New England Journal of Medicine. We knew that in a time of uncertainty, people need guidance and transparent communication. And I think across our systems, our ability to communicate with our physicians and team members has greatly improved and been so important to get everybody rowing in the same direction. And then trust hard-won clinical skills and judgment, I think is important. And then the last is, excuse me, I can't see that part of the slide. Diagnostic interventions and consults required to deliver care should not be withheld due to the pandemic. Next slide, please. So as Dr. Fales laid out slides early on, or earlier in the presentation, I wanted to highlight what we are seeing in West Michigan and really in Kent County. So we are seeing a clear second surge to the pandemic, and this started about the beginning of October. And the number of hospitalizations that we're seeing across our three systems has doubled at least from the peak that we saw early in the spring. At Spectrum Health yesterday, I know that we had 217 inpatients admitted. Recognize that this slide data is 6 days old because we had to have it in for the presentation earlier. But we are seeing capacity issues across our health systems, and this is greatly concerning for all three of us, and I'm sure many of you. Next slide, please. What concerns us even more is the number of positive tests that we're seeing in the community. So the number of tests has been slowly increasing that we're able to do, but we know that as a leading indicator, the number of positive tests that we're seeing in our 13 county region is a predictor for the number of hospitalizations that we're seeing. And it has a correlation of about 0.7. So we are very concerned for what we're going to see in the coming weeks. Yesterday at Spectrum Health, we had a testing positivity percentage of 14, which is the highest that we've seen. Throughout most of the summer, we were in the 2 to 3% positivity range. So something is clearly worsening in West Michigan, and I think it has a lot to do with relaxation of social distancing. And next slide, please. When we look at predictive modeling out in our capacity, the yellow line there is our capacity of hospital beds and ICU beds. The red line is our confidence interval for worst case scenario. The blue line is for best case scenario. And you can see that we are going to develop capacity concerns as early as the coming days for ICU beds and potentially later in November for the entire, or for hospital beds across Spectrum Health. Next slide, please. And with that, I'm going to turn it over to Dr. Biersack to talk about testing and treatments.
Thanks, Dr. Koistra, and thanks for laying out, the concerns that each of us are really experiencing right now. You talked quite a bit about testing, and I think, for a really robust conversation about testing, we have to start by first, talking through the natural course of COVID-19. So there's a lot going on this slide, but I want to draw your attention to the left where you see the SARS-CoV-2 exposure. And what we know is that there's an incubation period that happens between exposure and the onset of symptoms. And this period is typically about 4 to 5 days before symptom onset, but it could last as long as up to 2 weeks before we see that the virus has had a chance to latch on to lung and respiratory tissues, and we start to see viral shedding and then the onset of symptoms. And I think that's an important point because what we're seeing is a lot of folks who are immediately exposed to someone that has known COVID-19 and rush to get testing. But know that there is a period of time before folks will demonstrate symptoms and really express virus and have positive testing. So I think, again, it's important to really understand the disease process that's going on. We start to see a rise in terms of detectable virus, and we start to see a more likelihood that testing will be positive even before really the onset of symptoms. And then both those gradually wane in the weeks following. For mild disease, we tend to see that the symptoms last up to a couple weeks, but viral loads and shed virus tends to drop off rather quickly. And then in more critical disease, more severe disease, that process takes longer. Then you see, a couple weeks out, we start to see a rise of antibodies in response to the virus. And so these two kind of overlapping curves will help to understand better, why we use one approach to testing versus another. So on the next slide, I show a couple different means by which our health systems are performing testing. And by far the most a common method that's used is really nucleic acid amplification, or PCR, as many have come to know it. And typically what this involves is a nasal swab. Some often mistake it for a biopsy of brain tissue because of how deep this swab has to go within the nasal passage. But the objective is to achieve a respiratory sample and specimen that we can use, and then amplify the virus particles, nucleic acid specifically, within that sample in order to detect it. These methods they're really quite sensitive, and so the likelihood of a false positive test or a false negative test with this type of testing is really quite low. And the very specific nucleic acid sequence really doesn't have much overlap with a lot of other viruses or naturally occurring bacteria or human tissue. So this, at present time, is really the gold standard for testing. The other test that's shown here is a blood-based test. That's an antibody test. And, as I showed on that previous slide, the antibody response tends to occur several weeks after symptoms develop. And so antibody testing is not necessarily good for diagnosing an acute illness, unless, of course, that illness has lasted 3 to 4 weeks. But so it's used more for epidemiologic studies. We use it to see if someone has had a previous infection. But the mainstay of testing between our health systems has really been more of the molecular testing. We're starting to see antigenic testing now, more rapid tests that can detect viral particles. But the sensitivity or the likelihood that the test will identify a virus isn't quite as good as these other the PCR based testing, and so frequently needs to be followed up with PCR if the tests are negative. But this can be quite useful when we're looking at populations of people, when we're trying to really look at disease activity among a congregate facility or some other large population. On the next slide, I want to talk a little bit about this sort of metric that's gotten a lot of publicity, probably even more so now than in the spring, and that's this notion of test positivity. And Dr. Koistra spoke to how we're seeing a rise in test positivity, and this is it's important for us to follow, for a couple reasons. One is, as we look at the rate of positive tests, it helps us to understand how this virus is spreading within our community. It helps us to understand how that disease prevalence has changed. And it really has. As was shown, we've seen a dramatic increase in the number of positive tests that have occurred over the last month in particular. Again, this slide, a week old, current data from today shows positivity rate within Kent County is over the last 7 days risen up to 11.7%. So there's much more disease we're seeing week to week within our community, and even especially over the last 30 days. The other thing that looking at this positivity rate helps us as health systems is to look at just how adequately the number of tests that we're providing really is. We're at the point where thousands of tests are being performed on a day-to-day basis. We've been looking at folks that have symptoms, people that have been exposed or had a known close contact with someone with COVID-19. We're also looking at, patients who are having procedures and testing before procedures. We're looking at patients who are hospitalized and testing those. But as we've expanded testing as health systems dramatically since the spring, what we're seeing is that because of the prevalence of disease in the community, we're still probably not even testing enough. And so that positivity rate helps us to get a measure of that as well. On the next slide, I just want to transition to talk a little bit about what we're doing in terms of treatment. So, you get that positive test. What do we do now? There's been so much news and so much attention to some of the new and novel therapies that have been released. I think sometimes we forget that, the overwhelming majority of people that have COVID-19 are going to have mild symptoms. It's thought maybe it's about 80% or so of folks will end up having mild disease. And really the cornerstones, of treatment for COVID-19 are the same ones that, my mother used to tell me when I was a kid and sick. It's you need your rest, you need your fluids. In this case, you also need isolation, to prevent the spread of COVID from one individual to the next. So, a new onset of COVID-19 is for someone that's mildly ill is a chance to catch up on some reading. And the other mainstay of treatment is really, acetaminophen for headache, for fever, for muscle aches and pains and that sort of a thing. So again, for the overwhelming majority, this is the cornerstone of COVID treatment as it exists right now. For those who are more ill, though, on the next slide, I want to talk a little bit about how that novel therapies have really been directed toward the disease process itself and the sort of pathophysiology behind the virus. There's a lot going on here, and what's interesting is that even a recent slide like this that shows a lot of new therapies is already outdated because so much has happened within the space. So on the upper left, you see that SARS-CoV-2 virus and the proteins on its surface. You see it attached to lung tissue and then bind to different receptors that allow it to adhere, fuse to those healthy cells, and inject their nucleic acid sequence that then replicates and infects further tissue. So when we look at that whole process, different therapies have been aimed at different portions of that. So initially, the body mounts an immune response when it sees that foreign virus tissue, and so that involves antibodies. It involves a lot of different inflammatory markers. And in cases where folks are really severely ill or critically ill, what we think is that the body mounts just an inappropriately large inflammatory response, or a storm, if you will, that really overwhelms the body and its immune system. So there's been therapies that have really been designed to target this, and several have gotten quite a bit of attention. We now know that there's some monoclonal antibody therapies that Eli Lilly and Regeneron have announced. Those are now more being targeted toward patients who are earlier in the disease course, but we're going to hear a lot more, I think, from those pharmaceutical companies about their treatments in the weeks ahead. This is also the space where convalescent plasma works. So we know that patients who've had COVID-19, who've recovered, have antibodies, and if we use their plasma and the antibodies that they've developed and give it to patients, that there's a theoretical benefit. It's not totally borne out yet in the literature, but there's a thought that for high antibody titers and for folks that are early in their illness, there may be some. So that continues to be studied. As the virus enters into healthy tissue, antiviral therapy's been studied. Remdesivir is probably the leading and best example of an antiviral therapy that helps prevent viral replication that's been studied. As Dr. Koistra mentioned, we used to think that some anti-malarial therapies, chloroquine and hydroxychloroquine, would be beneficial in this space, but those have not borne out. And and had shown really no benefit towards either length of stay or mortality. And in fact, now we know carries some risk. So there's a lot happening in the therapy space. One other one that I just want to mention, because it really is now one of our cornerstones of therapy, is a medicine called dexamethasone. So it's a steroid that again helps to curtail that really profound inflammatory immune response to the virus. And if we look at the next slide, there's again a lot of detail, but just to know that we have now strategies for helping patients who are hospitalized and who need oxygen, who are sick and severely ill, that at present really are founded on use of antiviral, the remdesivir, and also dexamethasone. But we learn more every day about what's happening in this space, and therapeutic options continue to evolve. And I expect, we'll see even a different landscape, in a month from now. Dr. Koistra mentioned that we're using mechanical ventilation, I think, much more intelligently now. Early on in our learning around COVID-19, it was thought everyone should be intubated, early. We're now using more non-invasive ventilation and high flow oxygen to help patients breathe and to help raise oxygen levels. But ventilators still play an important role for the critically ill. And we've also learned a lot about the fact that simply by being on one's stomach and being prone, that it helps to improve oxygenation. And we do this even on folks who are on ventilators with machines like you see here in the lower right that help us to rotate patients and improve their oxygen levels. So, the old saying goes about an ounce of prevention. And so it's a good time to transition over to my colleague, Dr. Grifka, to talk a little bit about vaccine development.
Thank you, Matt, and good morning, everyone. And it's an honor to present at this great symposium today. And sorry we can't be there in person, but hopefully this Zoom conference is working. And Dr. Fales, Dr. Koistra, and Dr. Bierzak did a great job. They kept the bar pretty high. I hope I can reach it. But let's move forward. There are 4 types of coronaviruses and at least 7 different strains. Usually, a coronavirus causes just a common cold. There are 2 of the more severe strains that you may have heard about: the SARS or CoV-1 virus, the MERS virus, and then more recently, the SARS-CoV-2, also known as COVID-19. And now recently, there's been a lot of discussion about the concept of herd immunity. And what really is herd immunity? Well, herd immunity occurs when enough of the population has developed immunity such that the disease spread becomes improbable throughout the community. There's really only 2 ways that a community can develop herd immunity. One is through natural infection, the other is through vaccinations. And for a population to achieve herd immunity, at least 60% of the population needs to become immune. Next slide. Thanks. I wanted to show this to complement what Drs. Fales, Koistra, and Bierzak already talked about. This is called RT, or something called R0. But what this is really, it's a mathematical term that indicates how contagious is an infectious disease. It's sometimes described as the reproduction number. So if RT is 1.0, that means one person has the infection, he passes it on to one other person. If RT is greater than 1, that means that one person is infecting more than 1 people. And at that point, the disease is spreading through the community and increasing in prevalence. Hopefully, we get to have RT less than 1, which would mean that one person is infecting less than one other person. At that point, the disease is contained, it's less prevalent in the community. And the nice thing about that is when you get much less than 1.0, you can probably relax some of the social distancing precautions they've had to do. So you look at this slide back when the COVID-19 occurred in March, April, we were quite high, almost 2. Towards the end of May and all the way through almost the end of September, we were really less than 1, doing quite well, a little blip at the end of June. But as you can see at the right of the graph here now, we really have had quite a surge over the last several weeks in September and October. And now we're up to almost 1.3. So again, one person is affecting more than one person. And that really is why we're seeing this disease spread in great amounts through our community right now. Again, having us concerned, are we going to have the capacity to take care of these patients? Next slide. Okay, everyone's talking about the COVID-19 vaccine, and suffice it to say that vaccines just don't grow on trees. So I thought it'd be helpful to take a step back and really understand the evolution of vaccines. Because the first vaccine occurred really back in 1796 by an English physician, Dr. Edward Jenner. And I think the experiment that Jenner did back in 1796 would never make it through an IRB today. Fortunately, I think we're a little more sophisticated than that. What Jenner did was he took a cowpox lesion, which is a very mild infection, took the pus from an adult with one of these lesions. He scratched this 8-year-old child, as you can see depicted in the figure there, and then he inoculated and rubbed this pus in this patient's little scratch that he made. The patient developed some symptoms of cowpox, very mild illness, fever, cough. After 5-6 days was better. 2 months later, he took this little boy again, scratched him, and he gave him the smallpox vaccine, or the smallpox virus, excuse me. And fortunately, the child did not develop an infection. So this is really the first example of a vaccine providing immunity to a patient. I mean, we don't know about smallpox now, but back in the 20th century, they estimated it to kill over 300 million people, which is nearly the population of the United States. So really, Jenner showed that immunity can be developed from a vaccine. Next slide. Another disease that's had a great response to vaccine is polio, or poliomyelitis. Myelitis meaning inflammation of the spinal cord. It's interesting that President Franklin Delano Roosevelt contracted polio at age 32. In 1952, over 60,000 children were infected with polio. Thousands were paralyzed, 300 died. NYU came out with what they thought was a vaccine, and they gave it to 10,000 kids in New York. Unfortunately, it provided no immunity, and 9 children died from the vaccine. So unfortunately, that was a real black eye for vaccines. And really, there's a lot of tremendous loss of support for the vaccination process. But fortunately, just a few years later, Jonas Salk came up with the inactivated polio vaccine, which is a kill virus. I just thought I'd throw in for historical perspective. Dr. Salk did his fellowship at the University of Michigan, and then he was on staff for several years at U of M before he went to Pittsburgh. It was a very good vaccine. It was an injection of an inactivated vaccine. It was very successful, had a lot of support, saved many children's lives and illness. 6 years later, Albert Sabin developed the oral polio vaccine. And again, this is a nice example that there was so much support for the Salk vaccine. Sabin could not get any buy-in in the country, couldn't get any volunteers to test in the United States. He actually had to go to Russia to test this vaccine. The nice thing about the Sabin vaccine is it was oral. It was 2 drops of liquid in a child's mouth as opposed to an injection that Salk had. This live attenuated vaccine that Sabin developed. Oftentimes they mix this 2 drops of vaccine with cherry syrup. And you may have heard about a movie called Mary Poppins. There was a song, "A spoonful of sugar helps medicine go down." Well, that song's actually made in reference to the Sabin vaccine that was mixed with cherry syrup for the kids to take. But again, just a nice example of a very successful vaccine. Salk kind of inhibited the support and growth of the Sabin vaccine. We'll talk about that again in just a second. Next slide. Okay, so how many types of vaccines are there? Well, we talked about the kill virus, the IPV, and the live attenuated, the oral polio virus. The kill viruses are a little less responsive than live attenuated. So therefore you may need more doses of a kill virus as opposed to the live attenuated, which give a nice, strong, long-lasting immune response. One of the problems with the live attenuated virus is oftentimes they need to be kept very cold, 0 degrees or minus 20 degrees. We found out that problem when the United Nations went to Africa a few years ago to immunize a number of children. Unfortunately, they couldn't keep this vaccine cold enough, and all of it died. So again, which type of vaccine is important and how you transport it and how you administer it. More recently, there's been recombinant or conjugated vaccines, so for hepatitis, pneumococcal, where that will take actually a specific piece of the germ, be it a virus or bacteria, a protein or carbohydrate moiety, attach it to part of the vaccine, and then that will cause the immune response. And then lastly, there's toxoids, where some toxins have been made harmless, and that's injected and develops an immune response. Next slide. So those 4 were the most common and well-documented types of vaccines. Recently, there's been 2 new vaccines that have come out. The recombinant viral vector vaccine, which is very high-tech, very interesting. It takes a genetically engineered virus, and it produces a protein of the coronavirus. That the virus is geared to make up this protein. So now we have that protein, we can inject that recombinant protein into a patient to develop an immune response. And then lastly, there's RNA or DNA vaccines. This is really high tech, where it actually takes the virus, usually an adenovirus, and inserts some COVID-19 RNA or DNA into that virus. Well, then that is administered, and when that is administered to a patient, that virus, bacteria, and DNA goes into the cell, and our patient's cells develop an immune response, making that protein. And these are very high-tech processes, very exciting. There's a lot of venture capital being invested in this. But the fact of the matter is, right now, no vaccine has ever made it through either of these two pathways. They've all been the previous four. And there's been so much interest. There may be some inhibition, so to speak, of the other four techniques that have proven to be successful as new vaccines are developed. Next slide. So the FDA has several phases to get a vaccine for approval. The first phase really is just a test phase with less than 100 volunteers. If that goes well, it goes to phase 2, where there's several hundred volunteers get tested, they get examined. And then if that goes well, it goes to phase 3, which are thousands of volunteers. And it's just interesting to note that the quickest vaccine through the FDA ever was the mumps vaccine, took over 4 years. So we're like 6 or 7 months now into the COVID vaccine. So you can imagine this is an incredibly rapid pace, and we need to be very careful, make sure we have a safe and effective vaccine. Next slide. So where are we with the vaccines in the world? Well, as you know, with COVID-19, things are changing rapidly, daily even, with executive orders and management processes and medications. I can tell you this is up to date as of about 6 o'clock yesterday. I haven't checked this morning yet, but as of yesterday, there were 25 vaccines in phase 1 trials, 14 in phase 2, 9 are in phase 3, and there's 3 that actually have gotten a little passed through phase 3 and are close to being approved. And I think we'll talk about those on the next slide. Well, this is, again, it's Operation Warp Speed, because the time at which we're trying to get this vaccine created and tested is really fast. The 3 most common vaccines right now, they're in trials in phase 3, were number 1, the AstraZeneca. It was going well. Unfortunately, one patient developed transverse myelitis, like polio type symptoms. So that vaccine was put on pause for 5 or 6 weeks in most countries. It's still on hold in the United States as we try to determine, was this transverse myelitis caused by the vaccine or not? The Johnson & Johnson trial was doing well until one 20-year-old male healthy person had a stroke. And 20-year-old males usually don't get strokes. So again, that trial was paused for several weeks also, as we were testing to try to find out what was the cause of that stroke. The vaccine, which is actually looking pretty good right now, is the Moderna vaccine. It is an mRNA vaccine. Over 30,000 people have had it, and it's to the spike protein of the COVID virus, which you can see in a little caricature above. There's the COVID virus with the antibody attaching to that spike protein. And then one other vaccine that's making some progress is the RNA vaccine from Pfizer that's had pretty good trials, good results. So we'll see. Right now, those are the vaccines that are looking most prominent, most favorable as far as getting results. And I throw in the last vaccine in the bottom right-hand corner, the CanSino Bio vaccine. I'm not so sure how it's tested. There's no data published about it, but the Chinese government administered it to 10,000 of their soldiers. So hopefully we can track them to see how well that virus and vaccine is working. And I think that's what I have to talk about for vaccines. Thank you.
Thanks, Dr. Grifka. That was a great overview. You know, as we, since the beginning of this pandemic, we recognize that you know, this is really, it's had a profound impact on all of us and our community. But we do want to communicate, as evidenced, you know, by our presentation here together this morning, that we're all in this together, and our health systems have remained really shoulder to shoulder in how we coordinate our COVID-19 response. The 3 of us in particular have gotten to know each other well since this began, and you know, frequently have phone calls and late night and weekend text messages trying to stay connected and assuring that our response and our overriding goal is to protect the health and the wellness of our community at large. The other group that we've really stayed well connected with is our colleagues at the Kent County Health Department. And I think Dr. Nurali Bora, who is the medical director for the health department, said it really well with this quote. in the face of this pandemic, our communities adapted and implemented change faster than we may have previously thought possible. Throughout the past several months, our health department and our local hospital leaders have opened lines of communication and developed new strategies to more effectively confront COVID-19. We look forward to sustaining this collaboration beyond the pandemic as we work together to help our communities thrive.
Thanks, Matt. It was well stated by yourself and Dr. Bora, but I think it really is important so that the community knows, although there are 3 separate healthcare systems, for the last 8 to 9 months, we've been working really as one voice. And here's just 4 nice examples of what we've done working together to try to make sure we stem the tide of this illness in the community. You know, very regularly, we're having discussions discussing our COVID case volumes and number of patients admitted, the guidelines for treatment, what's working, what isn't working, and also what's our supply chain, where are we getting PPE and other things to help make sure our staff and our patients are safe. We've had some common visitor policies. We've had to restrict visitation, which we didn't want to do. I know it's inconvenient for patients and families, but it really was the safest thing for the community. And again, of course, talking about new sources of PPE, because this is crucial to keeping our staff safe so they can care for the patients in our community. We are very frequently, at least weekly, talking with our behavioral health partners. We're constantly talking with the subacute nursing facilities network and the health department, again, to make sure everyone's on the same page. And if someone has a great idea or plan, we can distribute that so we can all benefit from it. As Josh mentioned, we partnered to stand up a potential alternative site in case of a surge, and we didn't get that in the spring, but we may be getting it now. So that's something else we're renegotiating those issues to see how exactly we could stand up an alternative site. And again, lastly, we are constantly discussing our capacity to perform elective procedures, because we know we can't have people in the hospital for a simple procedure if we need that bed for a COVID patient. That said, as Josh mentioned, we have had people with morbidity and even mortality because we postponed procedures because of COVID-19. We don't want those people to have their health deteriorate also while we're caring for this illness. But it really has required all 3 hospitals to work together. We've done so. I'm proud to say we're working together as one voice, and we plan to do so to get us through this COVID-19 pandemic.
And the last way we're, not the last way, but another way that we're collaborating together is through our partners at the Michigan Health and Hospital Association. And really, regardless of, you know, what our political affiliations are, what our legislative bodies say, we came together as a group of health systems across the state of Michigan and really drafted a policy statement on what we think is most important to prevent the spread of the infection. And so thankful that we have that resource to come together as well and to make a statement to our communities. And with that, I will turn it back to you, Dr. Nagelkirk, for a question and answer facilitation.
Thank you so much for your presentation. That was wonderful, a collaborative presentation, and for working collaboratively for our community to provide the best COVID care in a coordinated fashion. So thank you all. And Dr. Fales has joined us. Thank you for doing that. Please, as the audience, put your questions in the Q&A box so that we can ask them. I have a couple, so we will get started. This is for each of you, they have asked, each panelist. Please, what are the lessons learned as we approach another more intense phase of the pandemic in our state and community, and what can we do? Shall we start with Dr. Koistra?
Am I off of mute?
Yes.
Awesome. You know, I think really looking to facilitate our capacity across our systems is going to be key. So I started an email chain the other day with all of our health systems in West Michigan to know that if, you know, one hospital becomes overwhelmed, instead of trying to transfer to the other side of the state, that we would look to transfer laterally to support each other. So I think that's one way that we're going to approach this a little bit differently than we did in the spring. I'll turn it to my colleagues for others.
Dr. Biersick?
I think Dr. Koistra did a really nice job of summarizing some of the important lessons learned. And as I mentioned, we've certainly learned a lot about how to approach the disease of COVID-19 itself. I think we've learned a lot about the power of collaboration with each other and with our county health officials. You know, as we look at how this disease has spread and the impact it's had. I think we've also learned about how interconnected our workforce, our schools, our hospital systems, the really the intricate web, of our society is so interconnected, and the public health, is such an important a piece of that. And so I hope that as we approach this next surge, that we're all doing so, mindful of that interconnectedness and support each other through this.
Dr. Gripka?
Sure. I think 3 points that kind of come to mind. Number one, there was this concept of pandemic fatigue. I mean, we've been at this for 8 months, and we're still a ways to go to get through it. And the community, everyone is just kind of fatigued through it. So we need to make sure we are cognizant of that and make sure we take care of ourselves to get us through this long and arduous process. Number one. Number two, I think taking care of our staff is important. We're focusing on the patients and the community, but our staff is important. They have lives, they've got spouses, they've got families and kids. Making sure we keep them safe and keep them healthy. And if they have got someone they need to take care of at home, they need to have that time off to take care of their families. So having staff to make sure we keep the hospital fully cared for is important. But again, our staff have done a great job for many months, and I hope we can continue to depend on them because it is getting rather long. And then lastly, I mean, we can't let our guard down. I think in the summer we were lulled into a little bit of somnolescence, if you will, where we didn't have a lot of disease. Things were looking quite good, and we probably let our guard down a little bit, and that's probably relating to some of the surge that we're seeing now. And we certainly are seeing the surge now, no question. We'll need to make sure we have our guard up, get this under control, so we can hopefully take this peak down to a valley again.
Thank you. And Dr. Fales?
Yeah, hard to disagree with any of those great points that were made. I think those are all applicable for not just West Michigan, but for the entire state. I think particularly the importance of thinking in terms of systems of healthcare, and it's kind of a Venn diagram with lots of interconnected systems. And so we have our health systems that are all, from a business perspective are part of the same system, but we have geographical systems and how just getting them to work well with one another. And Dr. Cloister kind of alluded to this about kind of rethinking kind of our traditional paradigm, where very often in Michigan and our regions, especially our more rural regions, there's just a model where we tend to move patients pretty quickly from smaller community hospitals to larger regional hospitals. And when those regional hospitals are overflowing, that model doesn't work well. So we're starting to see the Upper Peninsula has actually done a really nice job with this, where patients are staying in critical access smaller hospitals, especially those that don't need critical care services. And that's freeing up capacity within the larger regional hospitals. So just thinking out of the box, don't be afraid to think of different ways of doing things. Thanks.
Thank
Dr.
you.
Fales, to that point, we've really done a nice job standing up an EICU at our Grand Rapids facilities to help support our hospitalist teams in the regional facilities to care for patients and to keep them there.
Dr. Biersick, would you comment on the use of anticoagulants in hospitalized and non-hospitalized patients?
So that's an interesting question. There's been some studies that have shown that for hospitalized patients with COVID-19, that there may be an increased risk of either a blood clot, DVT, or pulmonary embolism, what we call thromboembolic events. So at present, though, the current recommendations are really to use medications to prevent both DVT and PE, or blood clots, within hospitalized patients, because they do tend to, or seem to be at higher risk. And the reasons for that are probably multifactorial. We've got folks with longer courses of illness, and what we don't understand is it have something to do specifically with the SARS-CoV-2 virus, or is it just the nature of their hospitalization that puts them at that risk?
Thank you. Do you see going forward that we will have SNF, SAR in West Michigan accepting COVID patients? How about Dr. Fales?
Yeah, so that's been a really huge challenge throughout the state. And understandably, a lot of our nursing facilities are have concerns about taking patients in that are COVID positive. But I can't tell you how absolutely mission critical it is for that to occur. And so we've been, working with long-term care facilities and making sure that their staff have PPE, that they're comfortable wearing PPE. Those are all things that have to happen. We're on the verge of implementing statewide a regional hub model with COVID care and recovery centers as nursing homes and nursing facilities that will be able to accept patients from hospitals that are COVID positive if they can't go back to the facility. So it's, we need everyone working on this. And I think a lot of times the focus ends up being on hospitals, but the hospitals absolutely need skilled nursing facilities to take our patients from the hospitals and allow them to have a safe and effective post-acute care period.
Any other person like to mention anything for West Michigan area? So that covers it. Good. Okay. Next one, what can be done making public health messaging more viral so that incorrect and misleading information, particularly on social media, can be contained and people do the things that they should for public health? How about Dr. Grefka?
Thank you. Certainly, social media can be very helpful. It can also be kind of problematic. And we've seen a number of people who, with, let's say, come and deliver babies, we have the moms tested before delivery, so we know if they're COVID positive or not, how to isolate them to protect their staff and the child also. Social media has gotten to be pretty prominent, though you don't have to get tested because you're going to deliver your baby anyway. Well, that does put the whole healthcare system at risk with our staff and things. And again, this is just propagated on social media. We're doing our best to stay out ahead of that and provide factual information in social media, posting things on our intranet and Metronet to make sure people can get the right information that's accurate. But we are fighting a little battle with some of the social media discussions that they aren't really helping us embrace the masking, hand hygiene, social distancing techniques that we need to keep the community safe. So it's a big battle, no question about that. There was a commercial last spring with the 3 CEOs of 3 healthcare systems. That was very helpful. But and we talked about doing that recently, but interestingly, it was hard to get some donated time because of this recent election. So hopefully now that that's hopefully behind us, we can get some more community messages out there, but we need to make sure we educate the community and keep pushing the fact that we need to social distance, wear our masks, and again, just be very careful with hand hygiene to make sure we prevent the spread of this, get on top of it, and get towards herd immunity.
Thank you. Dr. Kreuster, did you want to say something or?
No, I think that's well said, Ron. I'm sure many of you have watched that documentary, The Social Dilemma, and just how it divides our views completely and shows you what media you are biased to typically believe. We actually talked to the state yesterday, some of our state legislatures, about just having a message from Michigan, just from the state of Michigan, and kind of an ad campaign to do exactly what you were talking about, Ron. Because I think it needs to be a cultural shift for the state. It can't necessarily just be done through mandates.
Perfect. The next one is how do we determine fair distribution of scarce resources from a community-wide view? Is there coordination aimed at ethical distribution of things such as vaccine or other treatments?
Well, I see that question is asked by one of our ethicists at Spectrum Health, and we are very thankful that Jeff is on our team. He does a fantastic job. So we kind of came to this with our remdesivir initially because that was allocated by the state in a very scarce fashion, and we looked at our scarce resource policies for that. I think with vaccine, there's a lot of talk. Each of the states have been asked by the federal government to submit plans for distribution, and with that comes some prioritization. I know that they were talking about frontline healthcare workers potentially being at the top of that, followed by nursing home residents. So some of this, I think, is going to be kind of mandated by those plans that have been submitted. But otherwise, I'm certainly sure that we would involve our ethics committees and our scarce allocation of resources committees.
Just to add on to that, Dr. Koistra, I think about our response as health systems early in this pandemic, and there was quite a bit of communication between us and the other facilities and healthcare providers within the community about the resources that we had. There was a lot of support of each other in terms of testing early on, recognizing that kits and accessibility of testing supplies was scarce. And so I think part of this is all of us staying connected and collaborating in an ongoing way.
I think a nice example also, one of the PPE areas that we had trouble with was hand sanitizer. So fortunately, a number of the businesses in the community converted their business to making hand sanitizer, really helped us out. So making sure we keep the community invested also is important. There's a lot of great people and great companies in West Michigan, and getting them to help us is really crucial to our success.
Good. So are we beginning to learn and see what long-term effects this disease may have on individuals, and how will this affect our healthcare system and accessibility to care? How about we start with Dr. Biersa?
Yeah, it's a great question and a source of a lot of research at present. There are a number of individuals that have had particularly more severe and critically ill cases of COVID-19 that are experiencing things like shortness of breath, reduced exercise tolerance, even some cognitive effects on a sort of longer term basis than expected. And, unfortunately, we still have a lot to learn about, how to predict these kind of long hauler syndromes, if you will, how to predict the impact it will have on people, maybe what the risk factors for this could be, because we are also seeing this even in younger patients and patients that don't necessarily have substantial, chronic medical conditions. And so a lot remains, I think, to be learned about the long-term effects of COVID-19.
I think another interesting point to add on to what Dr. Biersack said was, we're talking about refocused, I should say, on a lot of the acute symptoms and process over the next 2 to 3 months or so. But for instance, cardiac problems, some people are having heart failure that's going to last for years. And even on another extreme, I was reading an article from some oncologists from MD Anderson over the weekend, and they're talking about we're going to see these effects from COVID 3 to 5 years from now, because there's many people who didn't get their screening mammograms or screening colonoscopy. They're going to show up with advanced cancer in 2-3 years. So we're going to feel this for a number of years down the road, unfortunately. That's why it's important to try not to cancel elective procedures to get these patients in and cared for now, so we don't kick this can down the road when their disease may be very, very more difficult to treat.
Okay, in regards to the SNF-SAR question, is there any plans for education of therapists and care managers being done for thinking outside the box to place patients and assist with opening up beds? For instance, both acute rehabs in the community are accepting COVID patients. We're unaware of these patients unless we are reached out to, and therapists recommend the level of rehab. Thoughts, Dr. Fales, would you like to start with that one?
Yeah, I think one of the comments made earlier is from, I think a lot of times when we think of state government, we think of it more from a regulatory standpoint, and we're not going to regulate our way out of this pandemic. It's going to really require lots of different approaches. And I got to say that probably the one area that one of several areas that we really probably can do better on is exactly what's raised here, is the importance of educating the broad workforce and the various disciplines that all need to be rowing in the same direction. And so I think there's opportunity and we can't always look to the state government to do this. We have GVSU, we have our educational partners, we have lots of people that can help with that educational piece to really be able to mobilize the workforce broadly that we need to do to have to solve this.
Wonderful. So initially, it was said that the virus mutated rapidly. How does this impact vaccine development?
Great question. I'll take that, or at least start with that one. So all viruses do mutate. In general, when a virus mutates, the new mutated virus is less infectious than the previous version of it. So that's hopefully helpful, number one. But number two, it could mutate enough to where the vaccine might not be as effective on this new strain, which is why we get an influenza vaccine every year, depending on the strains and the mutation type, to make sure we do have an immune response to that. But it is going to be a challenge. We're still so early into it. We don't know if the mutations that we're seeing are going to be responsive to the vaccines that we're developing today.
Thank you. A couple other questions that we have here. How accurate is antibody testing if people get that? Is that useful or not?
So I can take this, but certainly, Matt, feel free to correct me if I get anything wrong. Our antibody test that we were performing at Spectrum Health was pretty accurate because we would reflex positives to another test platform that looked at a different portion of the antibody, looked at a different antigen to look at the antibody response. So all of our positives were confirmed with a separate mechanism. So if there was a positive antibody test, I would feel pretty confident that there was a response to a previous infection.
Great.
I think the antibody tests they're very accurate, no question about that. What we don't know is how many, we don't have a titer, so to speak, but how many antibodies you need to have to be immune. And even the antibodies are just looking at B cell response, but there's T cell response, which can cause immunity also. So again, the antibody is just one part of our immune response to immunity.
And I will give the caveat that, I think that there are some probably manufacturers out there that have some antibody tests that are not as accurate if they're not confirmed in that manner. So it's really about getting the test done at a reputable location.
Perfect. I know that in one of the presentations, one of you had mentioned about getting people get tested if they're exposed and when your viral load goes up. If you're exposed, when should you get a test? Or should you? What should the general public do?
So I'll take a stab at that. So as I mentioned, there's definitely an incubation period. There's time from exposure to SARS-CoV-2 into the onset of symptoms, into the rise of, virus within their respiratory tissues. So we often hear and get questions from patients about, they were literally just with somebody who, was found out that they had COVID-19 and they're rushing off to one of our, drive-through test sites in order to be tested. And unfortunately, it doesn't work like that because the virus needs time to set into our healthy tissues. It needs time to replicate. It needs time to shed before it's going to be detected by that virus. I always think healthcare decisions, if possible, should be done, collaboratively with someone's primary care provider. And so, I think a call to one's the PCP's office is always a good first step. But typically, most suggest approximately 5 days or so after an exposure is a time when it's likely that testing is going to yield an informative result. There's definitely been studies that have looked at the fact that patients who were tested 1 day after high-risk exposure to COVID-19 will essentially not detect virus 100% of the time, and that increases, as the time progresses from that exposure. Anything to add, guys?
Yeah, certainly. Should one get tested is a very loaded question, if you will. And with the prevalence now in the community as it is, we're going to be exposed every day. So I think just an exposure itself probably is not necessarily an indication run to get tested. I think, as Matt said, talking with your primary care physician, knowing what's in your community, local community. But if we test everyone for exposure, we're going to be testing people a couple times a week probably.
And I would just also say that testing is beginning to become a constrained resource again in our community, even more so as the prevalence has gone up. So have the number of people with symptoms. And so all of those people are wanting to be tested. And so we may have to limit to symptomatic patients again.
I think to put things in perspective, back when COVID reared its ugly head in March and April, the state of Michigan was doing 2,500, 2,800 tests a day. Last week, one day we did 57,000 tests. So again, the volume that we're doing is great. And as Josh said, we could become constrained as far as who we can test because so many people just want to get it just quote to know unquote. And we probably need to be a little more medically sound about who we're testing.
Another question that comes up frequently is, should I continue doing my routine medical care in the light of so many resources being constrained for the treatment of COVID?
So I think this is where you have to trust the health systems to be able to turn on and off services that we feel like we can deliver safely. If we tell you that we can deliver safe care, you have to trust us that we can. And we certainly want to put the safety of our community as paramount for anything that we're doing. That said, if we feel like we can't safely provide services because we're constrained from a resource standpoint, we'll certainly let the public know. That's something that we don't want to do, but may become a reality as we were looking at this second surge.
Wonderful. Well, we're getting near the end, so I'm going to wrap it up. I want to thank all of you panelists. You did a phenomenal job. It was very informative. You shared wonderful collaborative pieces for the community, and we appreciate that. I want to thank those who attended, our audience, for listening and asking questions. We appreciate your participation. And I want to reinforce what all the speakers have said. It's important for us to continue to implement our public health measures to keep ourselves and others safe, masking up, social distancing, and great hand washing, and staying out of crowds, smaller groups is best. Registration is now open for the next Health Forum of West Michigan event that will occur on Friday, December 14th. Our focus will be on addressing health disparities. Again, thank you all for coming. Thank the panelists. And I hope everyone has a wonderful weekend as the weather looks like it's going to be spectacular. Thank you all.
Thank you. Be well.